Dr. John Gregory, ankle and foot surgeon at the Active Ankle and Foot Center here in Lebanon, and he'll be speaking to us about the ankle tonight. Welcome, Dr. Gregory.
Thank you very much, Stephanie. Thanks for those of you who are staying. Try to make it exciting. It's going to be bloody and gory. And pictures. So there'll be no sleeping. But it's okay. I'm just going to, I'll go into it. You can ask questions. I can go into whatever detail you want. I have things to look at. If those things kind of come up, I'll just get into it and we can go from there. So, ankle sprains are, it's going to be a little bit of a repeating theme to a certain extent because Dr. Loud talked about injuries, kids' injuries. This is going to be on the other end of the spectrum where some of these are also overuse injuries, but more adult focused and more in-stage focused, meaning multiple repetitive injuries leading to ultimately arthritis. But ankle sprains are the actual #1 sports injury of any sport that occurs, professional, college level, little kids. Of those injuries, studies have shown about 50% actually will develop chronic instability, where it ends up leaving them with ankle instability or ligaments that are torn, injured to the point where the ankle does not lock or stay into the mortise or into the joint the way it's supposed to. 72% of those patients, or those injured people, are unable to return back to their sport, either at their same level or at all. And then 15% of those injuries go on to having severe arthritis. We're going to get more into that at the end of the topic, and that's what we get into the total ankle replacement idea. So, as I said earlier, ankle sprains, most of them go completely untreated. People, time and again, and this is my own immediate family and patients. Most commonly, I'll see people who come in 3 months, several months later. I didn't do anything. It's still bothering me. It's still swollen, and never had it evaluated. Never did anything for it, and that's not a good plan. My repeating theme of that is, when in doubt, you want to brace it. If you have bruising, you've done significant damage. You've done enough damage to tear blood vessels, to probably pull soft tissue and ligaments and or tendons and or possibly bone. And I'll go into that. But in short, if it's bruised, you should brace it. If in doubt, you should brace it. The picture on your right side is, there's two different types of sprains primarily. Inversion, where the foot actually rolls inward towards the other foot, and then eversion sprain. You probably can't read that because it's kind of blurry and whited out. Eversion, where it actually rolls to the outside. And most people can't remember what happened. I just know I sprained my ankle. I fell down the stairs. I slipped on the ice. I was in a competitive sport, and I don't remember what happened. And well, that's my job, is try to figure out what happened and also go through some of the key points or the key areas that get injured with ankle sprains. And there are a lot, and they're commonly overlooked and missed because people don't do anything about them. They think to just go away after a while. If you injure the ligaments, which most people do, and we'll get into that, the most common ligament is in the front outside of your ankle. And when that goes, and it's usually not a complete tear, as in 2 pieces, what happens is it stretches and lengthens and stays lengthened. It's kind of like overstretching a rubber band. It doesn't go back to that short, snappy length. It stays long, and then your ankle is at that point unstable. If you've also done an injury severe enough to that point where you're actually tearing the ligament or stretching the ligament, you're going to get a lot of other soft tissue swelling. Swelling weakens the other ligaments in the area as well as the tendons, and can create more risk for it actually getting more damaged if you re-injure it. That's what really does a lot of people in is, they don't do anything about it, and then a week or 2 later they re-injure it, and that's where you create even more damage, such as broken bones, sheared off cartilage, dislocations. So you really want to protect it. When in doubt, brace it, and you really want to seek treatment. And ultimately, all of these need some level of rehab, no matter what you do, and that can be as simple as getting home therapy, which you can. Some people can receive just from going to their physician or coming to your buddies and getting lots of help. So what is instability? It's pretty simple, and we kind of talked about that already. It's basically where the ligaments that stabilize the ankle on either side rupture. The most common one, this is the hands holding the toes here. So the ligaments in this area here, they have fancy names, we don't need to know. There's 3 of them, most commonly 2 of those 3, and they tear from front to back most commonly if the bone doesn't go first. And when they tear, there's instability. And that's mechanical instability. We can all appreciate that if you grab an ankle and you can twist it like that, or you can pull it. That's dislocating. It's unstable. It's mechanical. But there's a whole other approach and thought process, which probably a lot of the people in Osteoarthritis are familiar with. But it's a functional instability, which is not the ligaments. It's not the mechanical part. It's what happens to the surrounding tissues as well as the body. So it can be neuromuscular, or neurologic based, and that has a big impact. Balance perception. The ligaments get torn, but the balance perception, which are certain receptors in the bottom of the foot and in muscles and ligaments and tendons rather, they're not damaged. They're still intact, but they get affected just because of the trauma, the swelling, and the way that you favor the limb. And if it's not being protected, you start to walk differently, and that further throws off your gait, which then in turn can injure your knee, your hip, your back. And these all affect your posture, and ultimately if you're favoring something for a super long time, you can get strength deficits. And that's why it's really important to have rehab. Ankle sprain care, like I said, repeating theme. The ankle brace is really key, and you can't just go buy the neoprene slip-on ace wrap thing. That's a glorified toeless sock. You can't wear that. You gotta go into a lace-up Velcro ankle brace, and I have one here. And if people want to see these, I have pretty much everything that I'm showing here for like braces, and we can talk about those. And if people want to see them, I can pass them around. But that's really crucial. You can get them at most drugstores. You can buy them in my office. You can probably get them here at Osteoarthritis. I'm not sure about that, but so brace it. And then the other things that even Dr. Lau talked about this, where you want to rest it, ice it. Compress it's going to come with the brace, elevating it, and doing other modalities, medications, things like that. The thing you have to keep in the back of your mind is it may not just be soft tissue. I see that time and again. People are like, it's just soft tissue. Don't worry about it. It's not a big deal. And I'll go on to show you later that that's not always the case. And the real trigger point should be extensive bruising. And it really, even if you're doing the brace and it's not getting better after a couple weeks, like if you're not seeing improvement, then that should be a red flag that there may be something more going on. And that's just my basic rule of thumb on that. And then again, you also want, once it's been assured that there's nothing major wrong that needs to be fixed, and it is soft tissue, then really getting into appropriate rehab as it's appropriate and being guided, balance, strength, gait analysis. You need to really evaluate the whole body, because sometimes these recurring injuries come from you never recovering from the first injury, meaning you injured a tendon or that tendon became weak in the rehab process and it never got addressed in the first time. So now you're susceptible for repeating sprains and getting more injury. And that tendon or that strength group, that group that's weak, if it was strengthened, then you can get out of this repeating ankle sprain scenario. So ankle sprain care. This is an example, and I have this brace. This is a custom brace, and the important thing about this is I often work from the theory that ligaments, if they're treated and protected correctly, they'll heal in a month's timeline. But if it's not being treated, it can take much longer. There are some scientific studies that say it takes 6 months to fully heal a ligament. Obviously, if you're re-injuring it, you have instability, it's going to take longer, and/or you're going to have to create other problems. So you need to progress slowly. People rush this. Really common. I'll see high school level athletes, and they take 2 weeks off, and they want to go back to their sports, contact sports, lateral motion sports, and they can't even stand on one leg, but they think they're ready to go because they can move their ankle and it doesn't hurt. And that's one of those moments where you have to do the tough love, and you got to slow down and tell them that probably not 100%. And that's where it's good to have good evaluation. Is there some other deficit going on? Is there muscle weakness? Is there ligament instability? Is there some kind of proprioceptive balance deficit? So you're really looking to try to address those things to enhance their rehab, as well as enhance their future performance. And that's where some orthotics can be helpful for improving balance once you step out of the brace, and it can also be helpful for addressing some of that functional instability, where you're trying to create a balance in a neuromuscular control. Some people have these injuries, have instability, have a difficult time rehabbing, and they're not candidates for doing surgery for whatever reason. And that's where these more custom braces, where it's an orthotic / ankle brace, all wrapped up in the same thing. And that's where these are very nice and effective. And not a lot of people do these. I do, but they're something, when patient gets them, they always come back and tell me how much people admire it and or how much attention they get from it, because it's different looking. So ankle instability, repetitive strains, sprains, the things that can happen when they don't heal. Collateral damage in this case. I can tell you on time and again, the people who come in who've gone through that no treatment scenario, and they actually are walking around with a fracture. And at that point, it's displaced, it's causing cartilage damage, and if they would have had it evaluated and addressed from the beginning, it would have been a simple fix, but now it's complicated. The middle, the ankle image here, these are just kind of addressing some of the common fracture points within an ankle that can happen, and oftentimes they're missed even unfortunately, when people go to the emergency room and get the appropriate evaluation. Sometimes these are missed because they're small, they're not displaced, but they're there, and that's where follow-up care is really important for assessing these injuries and evaluating them. More importantly than the fractures is the cartilage around them, and oftentimes that will get damaged, and I'll show that next. So you can get these small fractures around the ankle that develop. You can get the ligament injuries, and then the most common thing missed is this other fracture here off the. This is the pinky toe, the long bone behind the pinky toe is called the metatarsal. People crush this. People pop this off. There's a large tendon that attaches in there. The tendon that's one of the two tendons that's most commonly injured with this. And as you see people walking around with that injury all the time, their ankle's better, but their foot kills them right there, and nobody's ever evaluated or stressed it. And there's another fracture which you can get up higher by the knee, which is commonly missed, and that's more rare. And I don't have a picture of that. I can go into that. So cartilage damage, foot fractures, tendon injuries. One of my primary focuses in my practice is this tendon injury condition that happens. It's overmissed by colleagues, emergency rooms, and knowledgeable people. And it's the tendon that gets injured from a crush, and you can get this injury either from the ankle everting or rolling away from the body, or rolling in towards the midline of the body. It can either get crushed or it can get torn. And that's the next slide. But this is this is the tendon injury. This most common. This picture here. This is the medial aspect, or the inside of your foot. Have to think lay terms. But this tendon here is what holds your arch up, to put it in simple terms. And even when you invert an ankle, you can crush it at this level. It gets crushed between the ankle bone and the foot. Or if you evert it and you strain it this way, you can stretch it, tear it, just like you can stretch and tear the ligaments. And even a simple crush of that can weaken it. And if you're going through the classic, it's just soft tissue, it'll get better on its own. That tendon, just like the ligaments, lengthen and lose their elasticity. That's what happens to that tendon. It lengthens out, and if you have a hypermobile foot, you're going to have a tear of a tendon. You're going to have a more flat foot. And once that tendon goes, you never get it back. This is one of the conditions that's really life-altering. The people who come in and have this injury, it's an hour-long appointment, because you have to break out to them that it's never going to be the same again. Even if you repair the tendon, even if you do flat foot surgery, it's you never get it back. So when I see this with people, I'm pretty aggressive with it. You want to really control it. And if you take care of it, doing the brace, doing the cast, doing the time to recover, you won't turn it into this post-traumatic flat foot disaster that it can be. So this ties into the ankle instability, because when this tendon goes, as you can see the foot on the right-hand side, where it starts to swing out like that, that's offsetting the ankle. And it actually drives the ankle to move in the plane that it doesn't want to move. Your ankle, just like your knee, just wants to move in front line. It doesn't like all the side-to-side stuff. So if your foot's collapsing, pronating, everting constantly, you're going to tweak the ankle to the point where you can drive arthritis. You can accelerate the arthritis pattern. And that goes back to bracing it in orthotics and really evaluating and dealing with the neuromuscular componentry. But this tendon injury it's a big deal. It's a big talk, and I'm going to stop there with it because I can spend a lot of time on it. The cartilage damage, the one that flies under the radar through the emergency department and inappropriate X-ray evaluations is this crush injury that occurs on the top of the ankle. And this is where you got to have the bone, I guess, to show this one. And not everybody may be able to appreciate this, but this is a cross section of looking at the ankle, and within the ankle's composed of 3 bones. The most important bone it's called the talus. To me, my kids think it looks like a turtle, so that's kind of what I call it, the turtle bone. And it's dome shaped. Most of this bone is cartilage, and it's a delicate bone for that reason. The other 2 bones at the top, the long leg bones, and they form the cap of it. In carpentry, you call this a mortise and tenon joint, and it's a super solid joint, super strong. But when it goes big and it goes bad, and if you don't take care of it, it can happen fast. So what happens when you have an inversion crush injury like this? The tendon can get crushed over here, but if you really do a number on it, like you have that repeat instability, you can either shave off the cartilage or actually create a pothole in these arcs, these domes on top of the ankle. And that's what this image is here. It's a cross section of this bone, the front of the ankle, and this was the pothole. And this is old. There's inflammation about it. The bone's popped out, and it really looks like a pothole. And the way you fix it, this is open surgical fixing. We actually take out the pothole with a nice round tool, and spare you the terminology. And then you take a plug. This one's taken from the same bone. You can't rely on the cartilage being good there all the time, so you use a cadaver bone and replace that cartilage. So this is where you can actually, this is the best way to replace cartilage in your ankle, or actually in the body, because you're not replacing just the cartilage, you're replacing the bone. And that's a whole other topic in itself. But that's a real life case, patient of mine, where they thought nothing was wrong. So repeating that, you want to brace it, and that's where the slides just remind me to tell you that you want to take care of it when it happens. The good news is that it can all be fixed surgically. Isn't that great? Everybody likes that surgery. But surgery is my mantra. That is surgery like computers. They're only good when they work. And yes, I like to do surgery, but I only have to do appropriate surgery. And so all these things can be injured: ligaments, tendons, cartilage, and they can be replaced. Unfortunately, if you have them repetitively, and even if you have them fixed, sometimes you can go on to having arthritis, to the point where, just like your hips go and your knees go, your ankles go. And 10 years from now, ankles will be commonplace as hips and knees are for total joint replacement. I do them. Within the past 5 years, there's been a huge onslaught of new types of replacements out there. It's becoming more and more popular. I have an example of what one looks like. It's plastic, but it's what one looks like. And again, that can. I'll pass that one if I can find all the parts. It's kind of fun. Somebody broke my ankle in the office. So if people want, you can pass this around if you want to see it. But it's a multiple stem device, and just as you can see, this part, there's actually, you have to actually cut out this much bone to place this in, and this other piece goes into the talus. The real implant is not made out of plastic. No, this part is the articulating surface on the top of it is made out of a plastic-like material, and the rest of this is all metal, titanium, and that's more complicated. But you'll see a picture of it there. But for those that want to see it, which most people do, it'll fall apart. Don't worry about it. We can put it back together. So this is going to just back down some remedial. What is arthritis? Arthritis. Anything itis means inflammation. So anything that has itis at the end of it means it's swollen tendonitis, tonsillitis, ankleitis, arthritis. So joint inflammation. It's 100 disease. It refers to over 100 different diseases. So a lot of things can cause arthritis, and which ultimately lead to pain, stiffness, and swelling of the joint. The three most common forms that we all heard about, and we can probably find a neighbor that has one of these: osteoarthritis, rheumatoid arthritis, and post-traumatic, like I talked about earlier, where it's 70% of ankles are post-traumatic. Pain is in response to tissue injury caused by arthritis. It's the loss of the cartilage. The cartilage is the soft tissue, if you will, that creates the spacer between the bones. It's the sliding surface, and the synovial fluid is generated by the capsule. The synovial fluid is the oil that makes it slippery and slides nicely. And that synovial membrane, which provides the oil, is what inflames and creates an acidic environment, as well as a physical painful environment, because the synovial tissue can become so enlarged it gets entrapped in the ankle. Osteoarthritis, degenerative joint disease, which the cartilage cushion covering the ends of the bones basically deteriorates, thins out over time. We all have arthritis at all ages. Most of it's traumatic, but over time with these other conditions, diseases, aging, degeneration, we all get it. So affects 75 to 85% of people over the age of 65. That's 16 million Americans. Usually found in ankle, knee, hands, or hips. Leads to several physical disabilities. And contributing factors, like I said, age, lack of exercise, being overweight, previous injuries, and joint instabilities can all accelerate that process. Ultimately, the osteoarthritis, it's a general vague term, and a lot of people don't. There's no scientific known cause. And these are just some fancy pictures that show arthritis of the ankle. The x-rays are probably not really appreciated unless you know what a normal ankle looks like, but basically that joint's gone. This is a pretty common presentation where one ankle is huge, very wide, and the other one's pretty normal. And that's just all swelling of the deep capsule ligament structures around the ankle. Ankle arthritis, as opposed to the hip and knee, is primarily due to post-trauma. So that's what I was talking about in the beginning. Ankle sprains is the number one condition number one injury that happens in sports, and half of those people fail treatment and go on to instability. And this study, the latest number is 15% following those kind of injuries have recurrent ankle instability. And then there's some other information. Patients on average are much younger than hip and knee osteoarthritis patients, meaning the ankle sometimes goes sooner. Increased prevalence of the ankle osteoarthritis in the U.S., more than 50,000 new cases per year, not surprising. Conservative care options, really simple, and also not so. So we talked about the brace. I can pass that around because I found it. So this is just that custom brace, which is an ankle supportive type brace, which is the alternative for conservative care, where people can't undergo surgery for whatever reason, or don't want to go undergo surgery. That's a mechanical brace that fits in a shoe. It's custom. It's made specific to contour the arch and align it with the ankle. Beyond that is going into a cast boot, and there are actual prescription cast boots. They look like lightweight ski boots that some people wear. Pills, of course, there's always medication. Lots of people take chronic medication for arthritis, and that can be anywhere from Advil, Aleve to prednisone, which ends up having its own derogative effects on your joints. Injections. Injection therapy, these would be the wet needling. They can be, most commonly they're steroids. Today there's lots of other things coming out where there's injectable non-steroidal anti-inflammatories, and that's taking a lot of traction in the sports world. But if you ever have a patient who has acute renal failure after getting a Toradol injection, you may think twice about doing that. So that happens. And that's for the physical therapists out there. Probably the most unknown injection therapy for ankles. It's been FDA approved in the knees. The first one that came out on the market is called Synvisc. Syn, S-Y-N, for synovial fluid, viscous. It's a viscous solution. It actually, the way I describe it, it's injectable, it goes into your joint, it kind of creates a pillow in that joint. So it creates like this highly viscous fluid that sits there and stays there because it's so viscous it can't retreat out of the joint, and it creates a buffer for that joint. And very common in knees, and I bet somebody in this room have it. You can do that in the ankle. It's usually a series of injections, and most people advise them 6 to 12 months of relief, which can be a lot when you're in chronic pain. Most people, that is just a Band-Aid or a temporary transition until you make the commitment to either fusing your ankle or doing a replacement, depending on your preference. The hard part with the ankle part is the fact that it's now approved by the FDA. It costs, it's out-of-pocket expense. So surgical options is now expanding into 2 options. It used to be either fusing it, which is the traditional thinking in ankle surgery, and that's where a lot of people end up, and that is because the criteria for total ankle replacements is pretty rigid, pretty strict. The ankle is a more dynamic joint. It's it's further away from the hip area, so it has a much more leverage and torque on it. You also have to have adequate mechanics below the ankle joint in order to have good alignment through the ankle replacement. Some people get discouraged when you tell them that you have to fix their flat foot problem before you can do the ankle surgery, and that's where that's the big difference between knees and hips and ankles, is the fact that it has a steeper, more rigid criteria for placement. Ideally, you want to do ankle replacements in later years, 65 and older. I can say I've done it in 30-year-olds, and that's that's just because it's a rare incident, and there are those stories are true for ankles or for knees and hips as well. But you need to have good alignment, hip, knee, and foot. You want to have good bone stock. You can't be a smoker, and you have to be prepared for the recovery and the fact that there may necessitate other surgeries to update software, which basically means that plastic device that's in there, sometimes that wears out over time and you have to replace that. And that's good for about 10 years usually.
You're talking about this, the plastic on
Yeah, the white plastic part of that device is the replaceable.
Replace that?
Yeah, yep, and that's true of your knees and hips, most of them.
Is the rehab period the same as for doing the whole thing?
One of the big rehab differences is you can't walk on it at first. We have to let the bones heal around the implant. Whereas like your knees and your hips, you can walk on it day one, and that's another change in
I
point.
have been before the kids. Nobody told me I was going to have to do that.
10 years later.
So, 1980s total ankle replacements, when they first came out, they didn't have a very good rap, and I did these in residency and never liked them, and kind of gave up on them until they started remaking them, and there's several good ones out on the market now that are like this one that passed around the room. That's the Right Medical Prophecy ankle, and quite high tech and quite nice as far as simplicity of placing it. But you do have to remove bone, and that's one of the risks you have to be ready to sign on for. If something does go bad or it does have to be removed, it's a longer recovery period to rebuild the ankle to the point where you can fuse it or replace it. But there's a lot of these going in. So total ankle replacement, obviously if you've seen the sample that's been passed around, it fits into the bones. These are, one of the nice things about Right Medical is they do this custom fit where they actually we take CT images of your ankle before, and they design an implant that will fit in better, and they also design the templates. The templates are these devices that lay on top of the bone during the surgery to make the bone cuts. It's kind of the jig or it is the jig, in order to speed up the process. If we have a custom fit, it slides onto your bone faster, and you can do the cuts faster, and you can place the implant faster. And that's one of the revolutionary changes in total ankle replacements, is doing this custom fit, and it's a nice feature that no other company offers at this point. Right Medical does it. So that's the what the ankle looks like. It has these attachable pegs, and that is to, if you have a very tall person or you have a larger person, you want to make it stronger, you can make this taller, so it's adjustable. You can also make it shorter for smaller people. And I'm talking about these stackable devices. They can most commonly use it too, but you can go up to 4. So enhanced vertical fixation, multiple modular components to assist in anatomic sizing. The poly insert or the plastic insert is the white part on the bottom, which you can't see on this image because it's kind of whited out, but it's the white part on that display. So, actually I skipped one up here. The benefits of a total ankle, obviously it improves your function. If you've ever met anybody who's had a fused joint, it's pretty obvious that they don't walk the same. The toll that's placed on other joints from a total replacement or from a fusion they surmount, and you basically start to wear out other joints, knees, hips, backs. So preserving function is really the focus of this and the benefit of it, and allowing you to have a functional lifestyle. And these are some patient testimonies, and this is the disclaimer. This is where I read it on the flag. I'll leave it up. You can read it, but there's thank you and there's my information. But it's basically it says that it can fail, and you're gonna have to have if you have to have it redone or replaced. It's complicated, and it's a risk. It's you're putting a chunk of metal into your body. And I'm not saying it's the end all and everybody should do this. And not everybody can. The criteria is pretty strict. I'd say 80% of the people I see don't meet the criteria, and those fall into lots of different categories. But it's always worth getting evaluated and checked out, and always up for discussing it. So I have some brochures on the total ankle if people want that, and I have other information, and I can take questions, or you can all get out of here. I'll just, I'll leave this up here. That's the brochure on it. Go ahead.
If the total ankle, 80% of people aren't actually eligible for it.
That's just of what I've seen.
But
yeah.
I mean, so many people are not eligible for it.
Correct.
Then they go to, the next best choice then would be bracing, because the fusion has its issues with passing on to other joints and things.
That's right. Yeah, you want to kind of hold out as long as you can. Exactly. Just because that's, well, you can reverse it. You can choose to go to an ankle if you are, putting a total ankle in after it's fused. If things change where you met the criteria. most commonly it's body size that people fail the criterion, because you just can't put a lot of stress through the implant. And then the other part is the foot function. The joints below the ankle need to function right. Go ahead.
You know, it just occurred to me that what I've heard tonight is like injuries that occur in the elbow, hip, knees. I can think of all the exercises you could do to try and build up those parts to make them more injury-proof. But I have no idea what to do for an ankle. Do you have some favorite exercise?
Yeah. Well, yes. I was going to say you should talk to Bill.
I'm not ruling you out. I understand.
Yeah, I mean, this is where there are lots of things to do. I have a 3-phase book I hand out to people of ankle rehab things to do. Probably the most, well, and I'll let you chime in on that if you disagree. I'd say probably the most effective test and thing to build towards is doing single leg heel raises. And then going beyond that, I mean, doing it with weights or backpacks and such. I just read a study where they've always pushed the criteria that you should be able to do these single leg hops, or you should be able to go back, forth, side to side. And a lot of people don't do that, and they found that there's no correlation between being able to do this hop test and ankle stability or ankle strength. But going up on your tippy toes, doing that, like putting a 2x4 on the floor and going up off of that, and ultimately trying to do single leg balancing. And that's where you're working the functional instability, where you're trying to also improve your neuromuscular, your balance perception, your proprioception, because that's what goes in combination with the instability.
Well, Harrison runs up mountains, so he gets a lot of exercise pushing down that way. So I think you can you're probably in good shape with that one.
But no, it's a common question, and it is difficult because the muscles they're up by your knee, and there's a lot more gratifying knee stability exercises than ankle.
What about exercises that you do? I mean, I'm taking classes at the gym, and we end up
Doing the alphabet.
no, not always, but going one way and then the other, and I take water aerobics, whether I'm on dry land or in the water. It's always
Yeah, that's going to be focusing on range of motion. That goes into that. If you don't use it, you lose it theory. That pool work is good for working, doing protective strength building, but obviously it's not going to give you any balance, proprioception, neuromuscular feedback. Do you have a question?
Yeah, no, it's Dr. Gregory, it's great to know that you do total joint replacements for the ankles. It's not very commonly done, and I don't know anybody else in the area that does that. We're in an area that there's a lot of active people, that people in their 70s and some people in their 80s are still playing tennis or have a desire to continue to. So, it's great to know that they can be evaluated for that. If somebody gets a replacement like that, what is reasonable as far as their activity level?
Tennis is not a good one. Racquetball probably is definitely out. The high speed lateral activities you're definitely at risk, and I can't say I would condone that. Yeah, those are the ones I think people can give up. Skiing is fine. Yeah, you can ski. Downhill definitely. You're locked into a boot. But hiking, it's all about how well the rehab is. And if we get them into balanced single leg heel raises, doing the Karate Kid, then they're good to go. I'm dating myself.
How long have you been doing this?
Practicing.
Yeah.
This is my 17th year.
Here? Oh, no.
I've been here for 8.
Doing ankle
So-
replacement?
I did ankle replacements in residency, and I thought they sucked, so I didn't do them anymore. And then because people just, I didn't see good outcomes. And then, but the new ones have come out. I've gotten trained on all of them, and I like 2. And this newer one that now they do this custom fit is really nice.
You know Dr. Block?
I know Dr. Block. Yeah,
He
he's
didn't
retired,
mind.
yeah. Yep,
But he doesn't use that one, that in-home thing.
he didn't,
He uses
He
some
used-
French company.
yeah, he uses the Tournier one.
Yeah.
That's okay, that's the other one that's good. That one's more freehand, there aren't which is okay. It's the more what I call the more artsy implant.
The more artsy.
Well, it's medicine is science and art. And the total ankle is all about science and precision and reproducibility, and they have it set up in a system where anybody, I'd say anybody can do it once you get the nerves and vessels and stuff out of the way. But the Tournier one's a good one. I like the Tournier one, but I think the right medical one surpasses it on some levels.
So how long, it says you can't tell how long you expect to perform, but what's the oldest one you have going?
Well,
Mine's 3 years old.
yeah, around here it'd be about that,
Yeah. I think he has people a lot longer than that, but.
Yeah, I don't know how long he's done them. I think he's semi-retired now.
Yeah, he's done.
You have a question?
Yep, my girlfriend's an avid runner, and she was in a race this past weekend. And she had to drop out of it because of this pain that she's experiencing on the inside of her ankle and went up her inside of her foot a little bit. So at first she thought it may be sprained, but then she received some information to suggest it may be a stress fracture. So, but she's going to the doctor on Friday to get an accurate diagnosis on that. But and she can barely put weight on it now. She's on crutches, and she's doing the ace bandage thing, which she said probably not the best thing. So I'll let her know that thing at home.
Yeah, have her see if she can do a single leg heel raise test. If you can't, then it's probably her.
She can't.
Yeah, it's probably her tendon. If I had to bet.
Okay. But I don't know the difference in heal times were versus like tendon versus a stress fracture. Yeah, she's in her upper 30s.
Stress fracture, on average, about 4 weeks. Tendon, it can be longer if it's controlled right and we do therapy. It can be in that area, but maybe longer. So, yeah, she's trying to do the reach the beach, then she might be on the edge there. Any other questions? Thanks for staying.
Thank you.